Welcome to our module on health, medicine, and social problems. In this module, you'll get a bit of an overview of the sociological study of health and medicine, or epidemiology. We'll go over some brief and basic epidemiological terminology. And then, as usual, we'll do a quick overview of sociological theories. The remainder of the module is going to be focused on your reading with some supplemental videos to support the social problems that are reviewed in that text. But again, as usual in this video, I want to highlight the sociological theories so that you can have some frame of reference and paradigms in order to think about these think about these social problems. So moving forward. So epidemiology is the sociological and social science study of disease and illness. Epidemiologists are applied sociologists, and they look at data and track data, collect data, track data, analyze data about how individuals and groups interact and how those interactions, how their behaviors are linked to the prevalence of morbidity, disease, or illness, or the incidence. Prevalence basically is the rate at which a illness, a condition, a disease exists within a population. So prevalence would include new cases and also any pre-existing or old cases. So overall, how many people are struggling or dealing with this condition? That's prevalence. Incidence, however, is looking at new cases, right? So how many new incidences, how many new cases of this condition or illness are in existence? When we're talking about epidemiology, typically epidemiologists are focusing on those who are considered to be sick. Um, and that's really important to acknowledge because when we're looking at health, we're not only looking at those who are sick, right? If you look at the World Health Organization, international organization's definition for health, that is a state of complete social, mental, and physical well-being. And it's not just the absence of disease, the absence of any conditions, chronic or acute, but it is well-being, meaning that you are being well, that things are going good physically, mentally, and socially, right? And I think that in our society, we're so used to people lacking in one of these areas that when we talk about health, we don't kind of focus on that goal of all three of these areas being not just fair, but going well, right? Um, and so, yeah, and this is really a socially constructed idea as well. The idea of healthy, right? So remember, that's the World Health Organization's definition. Um, and that doesn't mean that it is the absolute truth of a definition. It means that it is a pretty good one that's been created by experts in epidemiology and in other fields. But of course, they have criteria that they have decided upon, just like other entities in society, right? Who else is determining in our society what's considered to be healthy and what's considered to be sick, right? Um, it's us, right? We make those decisions like, okay, does that really count as being sick? Or is that just like an everyday occurrence, right? And so society, the workplace gets to have a voice in that. I mean, think about it. Employers get to decide what's considered to be, appropriate use of time off for sickness, right? School, same thing, right? When it comes to like classes and being excused from things. Government and economy, obviously, our physicians and pharmaceutical companies, right? Insurance companies, and corporations who should not be involved in that area, but they definitely are. They get to determine whether a treatment is a necessity or not. Pharmaceutical companies, lobbyists, again, international organizations, influencers get to decide these things, and celebrities, and even religious bodies, right? Religious organizations still have the influence in our societies on, determining or dictating whether an illness is one of the natural realm or of the spiritual realm. So I want to go over some more of these terms really quickly. In particular, looking at fertility, fecundity, and then looking at different types of mortality. Because we often use terms interchangeably, or we don't really understand the full importance of terms. So for fertility, this is the rate of live births per 100,000 people. And those people are those who have the ability to birth a person, and those who are within childbearing age. And so you can do different kinds of scales for that, even just for childbearing age. It could be people between the ages of 14 to 54, right? Or traditionally, I think it's been like 14 or 15 through 45, right? These things change as our demography changes, right? And epidemiology in particular is definitely a study of demography, right? It's definitely it uses population studies very, very frequently in tracking disease and understanding how our social activity is connected to our health. So then you also have fecundity, and fecundity is actually a really important term that we don't talk about very often, because the concept that we usually um, use to describe like one's capability for becoming pregnant, for giving birth, is fecundity, right? Usually we use the word fertility not only to look at rates of actual live births per 100,000 people, but we also use it as a way of describing whether or not someone is able to reproduce, or whether or not a population seems to be able to reproduce, right? Any offspring. But really, what we mean there is fecundity. So it's not whether or not a person who is a birther is fertile or not, but whether they are fecund, right? And when we talk about fecundity, we're looking at this in a whole lot of different ways. We might be looking at environmental factors that can impact fecundity for a group of people, economic factors, or even just like what is the highest number of children that a person can give birth to at once in a lifetime, right? And so these things are really interesting. And some of it's kind of like, will you use it in the future? Maybe not, but it might be good trivia, right? When it comes to mortality, I think people often will confuse mortality or morbidity. Morbidity simply means illness, sickness, having a condition, whether it's chronic or acute. Mortality is death, okay? So everyone is going to have some sort of morbidity at some point in life. Mortality happens really just one time. And so with mortality, some really interesting measures of mortality are all kind of um, actually centered around birthing, right? And so we can tell a lot about the state and the health of a healthcare system based on some of these rates, right? Because what we can learn um, from maternal mortality rates, or the rate of birthers dying as a result of pregnancy or pregnancy related illnesses, and what we can tell from infant mortality rates, or the rates of children who have been born live dying before the end of their first year of life, these things tell us so much, right? So they tell us what kind of prenatal care is available and how broadly distributed is it, right? Can anyone access it, or is it something that is only accessible for the elite or for the wealthy, right? And then how advanced is it? How effective is it? Um, all of these things, right? And so it can tell us a lot about a society. All right, so getting into those perspectives, functionalist perspective. For the functionalists, this is really going to be an interesting one where they have some really strong beliefs. For example, functionalist perspective is going to basically state that being sick is disruptive to society, that illness is dysfunctional, that it threatens social stability, and especially illness on a large scale, like something we might see with a pandemic. So functionalists believe that being sick needs to be controlled so that there aren't too many people taking a break from society or from work, right? From their social roles all at once. And I think that anyone who was involved in the educational or an economic system as an employee or a student in the last, I don't know, 5 years has been able to see that kind of disruption, right? Or what happens when too many people are um, unable to participate fully in society at once. There's a really fun um, theory that goes in here. And I remember this being one of the theories where I was like, huh, this is interesting, right? It's the sick role. And the sick role comes from Talcott Parsons, who is a famous functional sociologist. And he says that in order to validate our illnesses, we are expected to participate in the sick role. And one of the reasons why I say that this is fun and super interesting is because I am really interested in, seeing how people react to it, how they feel about it, right? How they feel about these necessary like responsibilities of sick people in order to like that they have to fulfill in order to validate their illnesses. So there are social expectations, according to the sick role, of how a person who is ill must behave, right? Of um, how they're supposed to act. And it includes specific rights and obligations. So the rights, let's do that first. This is probably the part that we most agree with. The rights should include that you're exempt from your day to day responsibilities while you're sick, right? We acknowledge that if you are suffering from an illness, then you should, have some accommodations and some exemptions. That you are not responsible for your illness, that it's not your fault, okay? And that you have the right to care. And I feel like as we hear some of those, especially number 2 and number 3, some of us are like, "Well, but, aren't there some, correlations here where we can see a direct causal line that this person's behavior led to this end?" And yeah, okay, got it. But what is not possible is to judge every single incident, every single case um, of an illness and attempt to categorize them. Either you take them all or you take none. Okay. And so that's why you'll see, especially like I'm immediately thinking about like attendance policies and things like that for courses and for your course, right? That's why I have those late due date extensions because I'm telling you when you should have done it, right? That's the regular suggested due date. But here's your late due date. You don't have to explain anything to me. Just have it done by then. Because as long as you've tried to do it by the suggested due date, you should definitely get it done before the late due date. To the extent where you've waited until now something has like come up out of nowhere and now you actually cannot get it done, but you had a month and a half to do it, that's not on me, right? I'm not holding you responsible. I'm not withholding your ability to go seek care. I'm not holding you responsible for your illness, but you also have some obligations, right? So going back to the sick role and away from my assignment scheduling, you have obligations. You have to seek competent care. And this one can be tough because competent care is not free. So I think that an update of this, sorry, sorry, an update of this might be that you have to attempt to seek competent care, right? Are you trying to find, free clinics? Did you call and see if like this or that health center has a space? And I think that this one actually kind of holds well for some instances of acute illness, and that is that you must try to get well. What does that mean, though, right? What does it mean to get well? And what are we aiming for? Does get well mean to have a miraculous 100% recovery, right? Or is it to try to make the best of the situation and not to try to make it worse? So Talcott Parsons kind of also did some work that leans into connecting the sick role into these expectations and of roles and statuses altogether, like where the physician serves as a gatekeeper, and that's the person who deems a patient as ill or recovered. Um, and one of the things that we see there is that there's a function of that relationship, right? That allows, us to as like employers or your teachers or whoever, right? Whoever has an authority to make a decision about your activity within their institution or organization, that allows them to put that onus of making that decision onto a third party, right? But, and I totally agree with this, Parsons suggests that this role, right, of a physician being a gatekeeper is really similar to the relationship between a parent and a child, right? Because they're the ones who are giving you permission, right? And what we're seeing is that increasingly that those physicians are also like, don't put this on me, right? And that they are basically just like not wanting to be at fault, right? Not wanting to be sued, that they are distributing these awards, right? These awards of sick or recovered, you know, uh, in more lenient fashions than in the past, right? So excuse absences, giving prescriptions, diagnoses, referrals, permission to return to work or school, right? That this has become an area that's up for negotiation to some extent, because what they cannot do and should not be doing anyway is ignoring patients, right? And ignoring patients' input. So if I come into your clinic and you're like, oh, you're fine, you don't have a fever, you can go back to class. But I'm like, hey, look, maybe I don't have a fever, but I'm telling you, I don't feel well enough to go to class. And that person is, they're not going to excuse me if you don't say that you excuse me, right? Some criticisms of the sick role. It's up to the individual to determine their state. Like I just said, different people have different concerns. Different people are going to respond in different ways. I've seen people who, during their pregnancies, like they could run around a block or two, and not get winded. I could barely stand up without feeling like I was going to fall back down, right? And so some people, may be more cautious also, and some may worry over, any malady. As you get older, anything that starts acting weird, it's probably in your best interest to go and check on it like immediately before it gets out of control, right? Younger people may not actually notice, telltale signs that something's not wrong until it's very late, actually. And so, it's up to different people to decide for themselves whether or not their state, their status, their concerns are serious or not. Also, chronic illnesses are not treated the same as acute illnesses. They're not, right? Our society, and especially our economic system, is not set up for people to have long-term um, sick role, right? At least not easily. The hoops that one has to jump through, it's amazing, and amazing in a very negative, horrible way. And then there are simple factors, um, like, socialization or level of employment, a nation's healthcare scheme that influences one's ability and or willingness to adhere to the sick role altogether. So again, it's not as simple as like, here's these rights, here's these obligations, and I believe that it's just going to become increasingly complicated in the future. So my favorite theory when it comes to medicine and health is definitely going to be conflict theory. And this is probably going to be the theory that you're going to most easily connect to all the social problems that are discussed in the second half of the chapter. So conflict theories, actually, I like this comparison that our medicine and health systems of today are in some ways similar to state religions of yesterday, right? Where like our medicine has an officially approved like monopoly of the right to define health and illness, right? And to determine how it's going to treat illness and whether or not it's going to, you know, emphasize prevention versus treatment, whether it's going to be proactive versus reactive. Medicine isn't just about healing and recovery, it's also about regulation and prevention. And we are seeing that, as our medical system becomes more and more consumer oriented, that the focus on healing and recovery um, is becoming more prevalent. That we're becoming much more reactive, where, like if somebody has complaints or concerns about the possible onset of a condition, much of the medical field can't do anything, right? Hands are tied until something actually happens, right? Until it triggers a medical code, right? Until it triggers the need for a specific treatment, right? And you see this even with some drugs. I love looking at the commercials and advertisements and like all of the information surrounding the what do you call it, diabetes drugs that have been tied to weight loss. So like Ozempic or Wegovy or Manjaro or Zepbound, Victoza, all of those. Because if you look at different um, insurance schemes and things like that, it's not up to the individual case by case, um, you know, situation to decide whether someone is eligible for those drugs or not, right? And it's not because they won't be helped by them in some way, it's because they're so expensive, right? And so you're seeing that, until you reach a certain morbidity, like, oh, now you officially are diabetic. You were pre diabetic, and this drug could have prevented you from crossing over to being diabetic, but it's too expensive. I can't give it to you unless you're diabetic, right? Um, and so, and this is not that simple. It's not true for every single drug, but a lot of the research, a lot of the evidence points to this. For these drugs, people talk about, well, there's a safety concern. Well, there's definitely a safety concern that comes with the many comorbidities that can be linked to obesity, right? And so, what are we doing, right? Let's improve somebody's quality of life. Anyway, don't get me started on that. And so we look at how medical professionals are agents of social control, that they regulate behaviors, that they can enforce norms and values. Think about all of the times you have throughout your life needed confirmation from uh, medical practitioners and entities that you were, um, you know, healthy enough to participate in X, Y, or Z activity. And I struggle with this area because I definitely like believe that, hey, let the experts be the experts. If they say I need to have this, that, or the other before I can participate in yada yada yada, cool, right? Um, I feel like if it's something that potentially minimally puts those who are not that individual at risk, and those people want to go out there and practice whatever, then fine. But unfortunately, there aren't that many cases where individual medical and health behaviors don't actually get paid for by or impact others, right? So for example, if you're just like, hey, you know let me do that job that may be murderous for this one health condition, even though I have that health condition, I'm not just going to say, okay, well, you're the individual, you get to decide, because you might have kids, you have health insurance, right? And the costs of that health insurance, you're not the only one paying them, right? Um, and so there are very few cases. I mean, even when we talk about vaccinations, they work best when we're all taking them, right? And so, like, seeing all of these like cases starting to pop back up because we as individuals have decided to do our own research despite not being trained in being researchers. Don't get me started once again. Deciding that we're going to take healthcare back into our own hands, despite the fact that the demographic transition has shown that the advancement of healthcare and our vaccinations and things like that has prolonged our lives. We're living longer despite eating crappier crap, right? Um, that we, are having higher rates of survival through birthing and through infancy, you know. But of course, like let's just all just do our own thing and not impact others. It definitely does. Okay. So anyway, sorry, I'm going off on a tangent. And so, physicians examine more issues than they had in the past, which again, this is all about the framing of those things. It's about the social construction of these different things as being medical issues versus not, right? And for some of these, for many of these, I'm kind of glad that we are letting physicians, or not just physicians, we're treating these things using a more pragmatic model, right? So like sexuality, as far as like sexual function, old age, which is just something like, hey, that person's old. Back in the day, it was like they're old. Eh. But now we're like, no, we're going to treat old age, right? We want people to be comfortable even as they get older. Obesity, anxiety, child development, alcoholism, addiction, all of these things, right? So we see that there's this increasing medicalization of society. Although some say that this increase has expanded into what's the word I'm looking for? Unreasonable or unbalanced um like lengths. Um so one example here, one critique of this medicalization has been this like absolute control and regulation of areas that were previously seen as medical professional areas, right? But now these areas being kind of like taken over by those who bear the MD stamp or like some official certification. So like chiropractics, midwifery, right? Which is really interesting to look at. Midwifery, previously midwives were the gatekeepers of birth, and now they're actually seen as being invading the birthing space, right? They're now the alternative rather than the norm, which I think is a bit, not a bit, which is pretty excessive, right? Obstetrics in particular, if you go ask an OBGYN what their field is, they're actually mostly taught like obstetrics, or, you know, how to do like invasive procedures and surgeries in order to save a risky pregnancy, right? Um, or birth. So, yeah. So, of course, the conflict theory is also going to be looking at iniquities. They're going to be looking at iniquities within a country regarding quality of care and access to care, who benefits, who suffers, who dominates. And these inequities are discussed very thoroughly in the chapter as far as like locations of the country, inequalities in healthcare delivery, right? So like brain drain is a big deal here. The US is actually an area that drains other areas, where we get people like physicians from other countries want to come here to work, right, for higher salaries, which means that those countries, right, some nations will have fewer than one trained physician per 10,000 people, compared to the US, which recent stat had about 25 doctors per 10,000 people, right? And that we see these life and death consequences come from these things, these inequities. So, for example, life expectancy, right? How long are people going to live? And going back again to those infant mortality rates. So finally, we have the interactionist theories of health and medicine. This looks at the roles that are played by healthcare professionals and patients. So there's some interest here in how physicians learn how to play their role and their occupational role. In Intro to Sociology, we talk about reference groups. And usually I use the example of medical students who are referencing other physicians to learn behaviors, to learn their bedside manner, to learn how to treat and speak to patients, and sometimes actually passing on some really negative behaviors. We look at the nature of provider patient roles in diminishing care, where doctors are more likely to point to individual patients' shortcomings when it comes to their health status, or when it comes to their care, rather than looking at things like discrimination and prejudice, even when they can see very clearly, right, the evidence that this is the reason why this person has ended up in this physical state, and that it is not the individual's actions. Doctors will still find some way to avoid to and when I say doctors, I do not mean all doctors. I shouldn't have to say that, but I will just say it as a caveat, um, to point to individual patients' shortcomings. They also look at the impact of the ever-present screen. So 3 out of 4 doctors, if not, I mean, it's higher than that at this point, if not more, are using a device of some sort during their visits with a patient, and they're often turning their attention away from a patient and toward the screen. Right. Now, this is helpful in some ways. It keeps the patient from repeating the same information over and over again, which means that eventually they will probably become exhausted by that and start to give less and less and less detail and description, right? Um, so instead, however, of doing that in front of the patients, many advocate for reviewing files before and after the patient enters, especially before the patient enters, and for sharing the screen with the patient so that everybody can see what that doctor's looking at. Everybody can see what's being written down, and what notes, right, are being taken. Everybody's always suspicious about what's written in those charts. Also, on the interactionist side, they look at labeling. So this is going to sound a little direct, but what do criminals and patients have in common? The label of healthy or ill involves social definition from others, right? Other people define whether or not an activity is criminal or not. And other people define whether you are healthy or ill. And health professionals have the power to define certain people as criminals and certain people as being ill, right? And so that actually, there's a crossover there, right? Um, there are some behaviors and actions that actually now a medical physician can actually determine, was this something that, you know, is a result of an illness, right? Is it a result of a malady, or is it the result of this person having malintent intent? And this has changed throughout time. If you take Soc 30, racial inequality, we talk about these labels, right? And how they reshape how we treat one another and how others treat us, right? Once the skin color of Black people was seen as an illness, right? As a form of congenital leprosy, right? And I mean, like, there you go. Right. And that skin color was also linked to many beliefs about the type of person someone was as a result of their skin color, as a result of the shape of their head, right? Phrenology is that old scientific racism, which was seen as a medical field, right? Legitimate medical field in the past. Thank God we no longer believe that. But the desire to leave one's master during slavery was seen as a disease. And even when it comes to women's desires to work, to read, to think, to write, to remain single, or to remain child free in the past, also viewed as illnesses, right? In particular, you might have heard the term hysterics being used before. It's a sexist term. It is basically um, the term that roots from hysteria, right? And HYS, that root actually is to do with women, right? Like having a hysterectomy. So this is actually the disease that was used to that was used to capture like any abnormal women's interest or activity. What fun. There's a lot more there, obviously. And obviously, I am emphasizing this segment a bit more than usual because I'm currently on medical leave, right? And so, even the ideas about like who gets to go on leave and what the laws are surrounding that, this is definitely a topic of consideration here, right? So, yeah, really interesting stuff. Um, Enjoy looking at those social problems. Enjoy. And take care. Till next time.